Welcome to the session on weight bias, stigma, and body image. Myself, I'm Sonia Wicklum from the University of Calgary, and Sarah Kirk is my co-chair. We have a great list of presentations this afternoon, but we have 8 of them to get through in 2 hours, so it should be very stimulating. We'll maybe all stand up and stretch after 4 of them. But we'll get going right now with Amanda Rafoul from the University of Waterloo. And her presentation is Dieting and Other Risky Behaviors Among Adolescent Girls, Implications of Obesity Prevention Initiatives. Thanks.
Okay, so I have no relationships with commercial interests to disclose. Pretty easy. Okay, so as was mentioned, I'm going to be talking about some work that we did investigating dieting and other risky behaviors among adolescent girls, and then close off with a bit of a brief discussion on how we can use this information moving forward with obesity prevention initiatives. So dieting is a term that's used pretty differently across studies and fields of research, but for the purpose of this study, it's loosely defined as an intent and behavior to change weight. And so these behaviors often fall along a spectrum, where on one end we have more healthful sort of intentional weight loss behaviors, and as we move along, they become a little bit more unhealthful and even become disordered. So all forms of dieting are much more common among girls and women than they are among boys and men, because the construct of dieting differs significantly by gender. But studies on North American and more specifically Canadian adolescent girls show that 1/4 to 1/2 of them are trying to lose weight at any given time. Now, similar to obesity, the drivers of dieting are very complex. There are drivers at the individual level and even broader societal pressures for girls to engage in dieting. Now, girls who diet are more likely to have a poorer dietary quality score, gain weight and be affected by overweight and obesity, and develop an eating disorder or disordered eating patterns than non-dieting girls. But dieting also has effects beyond these health and weight-related consequences, and it may actually belong to a cluster with other health-compromising behaviors among adolescent populations. So among adolescents, these health-compromising or these risky behaviors tend to cluster and continue on into adulthood. Dieting has been independently linked to the following 3 behaviors. And as many of you probably know, there's a very large and established body of literature linking dieting with smoking. Adolescents view smoking as a tool for weight control, weight loss, and appetite suppression. And multiple longitudinal studies, primarily conducted through the 1980s and 90s, have established a sort of a longitudinal relationship between dieting at baseline and smoking at 1 and 2 year follow-ups. Dieting has also been linked to binge drinking. Now, although there are no known longitudinal Canadian studies looking at this association, international and American data have suggested that dieting at baseline does correspond with an increased risk of binge drinking, again at 1 and 2 year follow-ups, although the pathways underlying this are a little bit less clear than with smoking. And then finally, dieting has been independently linked to frequent breakfast skipping. So similar to smoking, adolescents view meal skipping as sort of a tool for weight loss and weight control. And so among girls, dieting has been independently associated with each of these 3 behaviors. But for us to inform comprehensive chronic disease prevention, we need to establish stronger longitudinal linear associations, not only between dieting and each behavior by itself, but between dieting and each cluster of these behaviors and how they pair together. So there's a lack of longitudinal Canadian research, particularly in the past decade, that demonstrates the potential causal relation of intention to lose weight and clusters of risky behaviors. And so in this study, we aim to determine the rates of smoking, binge drinking, breakfast skipping, and clusters of behaviors among dieting and non-dieting adolescent girls at a 2 year follow-up, and then to look at the associations between dieting at baseline and each of the behaviors independently as well. And so to answer these research questions, this study consisted of cross-sectional and longitudinal analyses of data from the COMPASS study. So COMPASS is a prospective cohort study investigating how changes in school policies and programming affect youth health. They do this by using a variety of school and student level measures and using a convenient sample of school boards and schools in Ontario and Alberta. The student-level data collection occurs annually through self-reported surveys that are completed during class time. And so this study in particular made use of data from years 1 and 3 and used data from only those students who identified as female, had observations at both time points, and provided information regarding their dieting status, which resulted in a total of 3,386 girls. Now, of these girls, 3/4 I self-identified as white, and there was a fairly even split between girls who were in grades 9 and 10 at baseline. Those were the only 2 grades we looked at, because by follow-up, they would be in grades 11 and 12. And so, as you can see in the pie chart, the majority of girls self-reported heights and weights that would place them in the healthy weight category, as you can see in the darker blue. But 1/4 of the girls in the sample, in the darker green, did not report their height or weight, and so it's BMI not stated. Over half of the girls reported dieting to lose weight at baseline. Dieting was actually significantly associated with BMI status, but there were no differences in dieting by grade or by ethnicity. Now, the prevalences of smoking and binge drinking at baseline were 3 and 11%, but the prevalence of breakfast skipping, as you can see, was much higher, with over half of the girls engaging in it. The co-occurring behaviors were not very prevalent at baseline. Only 1% of the girls were engaging in all 3 behaviors. Now, as you can see, as the comparison between years 1 and 3, engagement in each of the individual and co-occurring outcome behaviors increases from years 1 to 3, with the largest prevalence increase being demonstrated in binge drinking. So if we look at the dieting specifically, there's some interesting patterns in how the girls move back and forth between dieting status. By follow-up at year 3, 1/5 of the girls who were dieting at year 1 had become non-dieters, but 1/3 of the girls who were not dieting at year 1 became dieters by year 3. And similar to the individual behaviors, the prevalence of clustered behaviors went up from years 1 to 3, with the largest increase in the binge drinking, breakfast skipping pattern specifically. Now, at baseline, dieting was significantly associated with each pattern of multiple behaviors. And it's interesting to note that if you look in the first line of this chart, the proportion of dieters and non-dieters among girls engaged in 0 behaviors is exactly the same, 50%. But as we move down the chart, looking at girls who engage in 1 behavior or more than 1 behavior, you can see that the proportion of dieters in the bottom bar is always higher than the proportion of non-dieters. And this is much higher, or this discrepancy is a lot greater as we move into the patterns of binge drinking and breakfast skipping, again, and the pattern of girls engaging in all 3 of these behaviors. We found that girls who dieted at baseline were 1.3 times more likely to be smokers by follow-up. The risk was slightly higher among girls in grade 10 versus grade 9, but ethnicity and BMI were not associated with smoking in this model. Girls who dieted at baseline were 1.4 times more likely to be binge drinking by follow-up than non-dieters. Girls who were non-white and those who didn't report their height or weight were at a lower risk of being binge drinkers. And finally, girls who dieted at baseline were more likely to be breakfast skipping by follow-up than non-dieters. And the risk was significantly higher among girls who were non-white, reported heights and weights corresponding with the overweight category, and those who had missing BMI data. Now, unlike the previous models I just showed that looked at the individual behaviors as outcomes, the ones with the co-occurring behaviors as outcomes did not differ by ethnicity or by BMI, and so those aren't included in this table. And so girls who dieted at baseline were at a significantly elevated risk of engaging in all of the co-occurring risky behavior patterns when compared to non-dieters. Dieters had the highest risk of actually engaging in the binge drinking and breakfast skipping group, which had a relative risk of 1.64. And also, as seen in the second row, there is a slightly elevated risk in engaging in these behaviors among grade 10s. And so overall, we look at this data and we determine that dieting is an incredibly common practice. 70% of the girls were dieting at 1 or both of the time points in this study. Obviously, this is concerning because of the associated health risks with dieting, but it's also concerning because of the fact that we now see that dieting is not only a weight-related behavior, but that it has implications for overall chronic disease risk. Not only does dieting have its own weight-related consequences, but it may actually implement or infer that we will see an increased risk of smoking, binge drinking, and breakfast skipping among these girls. And so now in relation to obesity prevention in and of itself, this might be a potential area of concern. because weight-related interventions that specifically target or promote a loss in weight among this population have the potential to increase dieting. So although this is already a common behavior among some at-risk groups, like adolescent girls, the potential of these initiatives to promote longer periods of dieting is concerning, especially because of the fact that this may present unintended consequences for other risky behaviors, including chronic disease. And so we talk about using complex systems a lot in obesity, and yet we sometimes fail to acknowledge that the impact that our initiatives might have on outside of weight-related behaviors and on chronic disease prevention or risk in general. And so in using a systems lens to address obesity prevention, we may try to consider conceptualizing diet and other behaviors and their clusters as drivers within the system of obesity. Obviously, these results carry some caveats. The use of secondary longitudinal data makes it difficult, especially when we're using self-report measures, which might be prone to some bias in reporting. It's also important to note that 1 in 5 girls provided intermittent data. That is, we have data from years 1 and 3, but not from year 2. And that a pretty large chunk of the sample in year 1 were not present by year 3. And so our estimate might actually be conservative, as non-response or non-participation in longitudinal studies might be indicative of more risky behavior engagement. And it's also important to note that the COMPAS sample might not be representative of all Ontarian or Canadian girls because of the fact that over 3/4 of them self-reported as white. Thank you.
Anybody have questions?
Sure, so the question is the pretty standard question that's used across many surveys, and it's what are you trying to do about your weight? The options were lose weight, gain weight, not trying to do anything, or stay the same weight. And so dieters were classified as lose weight versus everybody else. Yes. There wasn't much detail about the types of behaviors or for how long, but that's the question.
I actually prefer it that way, but that's saying that 7 out of 10 girls are actively trying to lose
Yes. Yes.
So I just have a question for you.
Sure.
Did they do data on, did it also include information about level of education, say, of parents or things like that?
Sure, so there was some data asking about inferring family affluence. I don't think that there was a measure in and of itself of parental level of education in the survey.
And any link?
I didn't take a look at that variable. Yeah. Great.
Any other questions?
Thank you.
Okay, we're going to tag team today. So it's now up to me to introduce our next 2 speakers. It's Sarah Nutter and Angela Alberga. Sarah is actually from the University of Calgary, and Angela was from the University of Calgary, but now has moved to Concordia. And they're going to be presenting on What's in a Name, the influence of framing obesity as a disease on weight bias.
Hi, everyone. Okay, we'll have to move the microphone for you after. So we're going to be presenting work that we've done as a team. So Sarah and I are tag teaming on this presentation, but this is the communal work of a couple different members at the University of Calgary. So Dr. Kara McInnes and John Ellard and Dr. Shelley Russell-Mayhew, who are not here with us today, but we will present on their behalf. And okay, we don't have any conflicts of interest to disclose, so we can quickly go through these. So I want to start off with this particular slide because we know the pervasiveness of weight bias occurs in several different sectors. And one thing that the Canadian Obesity Summit has done such a great job on is actually making us hear some of these personal lived experiences that we hear every morning at this conference. And we now also hear these lived experiences of people experiencing weight stigma in interpersonal relationships, in education, in healthcare, in public policy, in media. So we know the pervasiveness exists across all sectors in Canada and also across the world. These health consequences are pervasive, and they also affect the mental and physical health of people living with obesity. This stress can affect their eating and physical activity behaviors. It can affect physiological reactivity through increased cortisol, through that stress. experience of weight stigma. It can also affect healthcare services, and that can also ensue in weight gain and other affective behaviors. It can affect our psychological health and distress and physiological health. So we know the consequences of weight bias are pervasive and they occur at several different levels and across individuals. But what we don't know is actually the effect of declaring obesity a disease on weight bias attitudes and beliefs. So one of the main reasons why obesity was declared as a disease by the American Medical Association in 2013 and then followed by the Canadian Medical Association in 2015 was perhaps because declaring obesity a disease could actually decrease weight stigma and improve our attitudes and beliefs about people living with obesity. However, we don't have the quantifiable evidence to actually say that that's true. So what we wanted to do as a team was actually evaluate this question and figure out what is the effect of declaring obesity a disease on the perceptions of people living with obesity. So we as a team, we want to work on a study that was previously done by Hoyt et al. In 2016, and they had 204 participants. So they initially had participants through online questionnaires. They administered several questionnaires, including the beliefs about obese persons, anti-fat attitudes questionnaire, the universal measures of fat bias, and an implicit measure of theories of weight. And they were randomly assigned to two conditions. One condition being the obesity a disease condition, and they had to read a New York Times article about the declaration of obesity being a disease. And the second condition was weight is changeable through an article in Psychology Today. And what they found was that when the condition was actually obesity being a disease, it actually decreased weight stigma through the decrease in blame. However, so they call this the obesity asymmetry model because it's not a symmetrical relationship. It decreases weight stigma through decreased blame, but it also increased stigma through belief that weight is unchangeable. So that was their results that they found, the major results from their study. Now, some of the limitations was that they just had two conditions. They did not have a control group, but they also need to further examine the effects of actually declaring a disease versus not a disease, and examine the influence of other moderating factors. So that's where we want to work on that previous study, build on those findings, and see what the results could be. So our current objective was actually to experimentally investigate the influence of framing obesity as a disease on the attitudes of members of the general public. How we did that was using Crowdflower. This is an online recruitment platform for Canadian and US participants. We recruited 309 participants aged 15 to 73 years old, a normal BMI distribution. And the questionnaire they had to complete took them about 25 minutes. The questionnaires that we included were just a demographics questionnaire about weight, age, sex, ethnicity, occupation. And we also had them develop, or actually answer a questionnaire about fundamental values, and these fundamental values have to do with right-wing authoritarianism, social dominance scale, global belief in a just world, and they also had to perform an examination of the evaluations of people with obesity using an attitude thermometer. And they also answered a question about the quality and quantity of contact of people living with obesity, just to see how often they were in contact with people living with obesity. We then randomly assigned 3 conditions. So one condition was obesity a disease, the second condition was obesity is not a disease, and the third condition was an HIV article. So we created these articles ourselves, generally using a lay audience language. We created these articles and it was called Health Mail, just so that they would obtain the credibility of reading this type of article. And we spoke about obesity being a disease, the other one not, and they were very similar in terms of wording, the same content, the same amount of words, and the HIV condition was purely about HIV as our control condition. That was lacking in the previous study. So what we did, we then evaluated the post-manipulation after they were exposed to these conditions. We did a post-manipulation check, so we asked them to what degree you actually think obesity is a disease, yes or no, and we had to verify that with the condition that they were put in. And then we asked them to fill out a couple of questionnaires about affect, disgust, empathy, weight controllability, and explicit weight bias. And Sarah will continue on the results of our study.
Thank you. Okay, so while we won't be presenting all of the results from this project today, we will be sharing with you some of what we think is most exciting. While we did not find any direct effect of our manipulation on weight bias, the manipulation directly impacted 2 variables which then influenced weight bias. So we're going to take a closer look at these 2 mediation models today. The first that you see here on the slide relates to how our results when we compared the obesity as a disease condition to the other two conditions combined. And we found that compared to participants who read the other two articles, those who read the article describing obesity as a chronic disease had less negative affect towards individuals living with obesity and subsequently less weight bias. The second model also displays our results when we compared the obesity as a disease condition to the other two combined. And here we found that after reading the article, participants from the obesity as a disease condition perceived obesity to be less controllable, which was then associated with reduced weight bias. And this effect was especially significant for participants who had stronger beliefs in a just world. So in other words, participants that more strongly believed the world is a just place where people get what they deserve. They had lower perceptions that weight was controllable, which then reduced their level of weight bias. So when people high in the just world perceive obesity to be less controllable, perhaps they're less likely to believe that people living with obesity are more likely to believe that people with obesity are less personally responsible and thus may have less negative attitudes. So the results from our study are exciting because they add to the results from Hoyt et al., who were the first to look at the framing of obesity on weight bias. Framing of obesity as a disease on weight bias. We add to the conversation by providing information on the effect of this declaration towards affect towards people with obesity, as well as the beliefs about the controllability of weight and how these then influence negative attitudes. And we also built upon the design of Hoyt et al. By adding a control group. In addition, our results are consistent with what we know about what makes weight bias interventions successful. In a systematic literature review on weight bias interventions among health professionals, we noted that intervention strategies that seem to be the most effective in increasing positive attitudes towards people living with obesity are increasing positive attitudes and also providing information about the complexity of weight in order to decrease these negative attitudes. Given our results of that framing obesity as a disease impacts both affect towards people, increases positive affect towards people with obesity, as well as decreases weight controllability beliefs, we believe that researchers should consider designing future interventions that use multiple approaches to the reduction of weight bias, and to see if this has stronger and potentially longer lasting effects. One of the major limitations we recognize in our study is the disproportionate number of participants between groups who failed the manipulation check. So after reading the article, participants in each group were asked whether or not the article was discussing the health condition they read, so obesity or HIV, as a disease. So while we speculate that these differences may be explained due to the subtle nature of our manipulation, we are unable to know for certain why this occurred. Nonetheless, we think our results are an important step towards better understanding the impact of the declaration of obesity as a chronic disease on weight bias. We believe it's important for future research to investigate the impact of this declaration among health professionals and researchers who work with patients living with obesity, as well as among primary healthcare professionals who are most often the first point of contact. We also wonder how the combination of different strategies of weight bias reduction, as well as the order of such strategies, within an intervention might impact attitudes in the short and long term. Thank you.
Okay, do you have any questions? I have a couple.
Sure.
I'm just interested in this whole idea of weight as unchangeable, because we're seeing that as one of some of the research that we're doing. If thinking weight's unchangeable actually increases stigma, how do we frame it? Is I guess my question.
Yeah.
Did everybody hear that? I'm conscious there's a mic sitting here that we're not using.
The question was if we frame it differently. So you're asking how we should frame it, because if we say it's unchangeable, but that's increasing stigma, then how do we frame it to actually improve our attitudes?
Yeah.
You know, Sarah, there's no magic way to answer that question. I think you already know that too. But a couple of components. So what we saw from our systematic review for weight bias reduction amongst health professionals was that there were a couple criteria that were necessary to understand weight as a complex issue weight that there's so many other factors that influence weight that are completely outside the individual control, but also, exposing empathy, making sure they have positive contact with people living with obesity, prolonged contact and exposure. So there's a couple of different things. I don't think we can just present weight as unchangeable, but I think we have to provide other experiences with people living with obesity to make sure that we help reduce weight bias. Do you want to add?
Yeah, I was gonna, and one thing that weight bias researchers are often very critical of is the messaging around weight. And so it's come up a lot at this conference in terms of people keep getting the messages of eat less and move more. And a lot of the time that's messages that people are receiving from their doctors, from public health campaigns, and just general societal messaging within the media and among peers. And so if we can change that dialogue to more accurately reflect the complexity of obesity and not that weight is just as simple as eat less and move more, then perhaps those attitudes can be reflective.
So I guess that's what you mean by those multiple approaches then.
Yeah.
So it's using all those different things.
Yeah, increasing, empathy through hearing personal stories, increasing the knowledge of how complex weight is, as well as some other approaches, potentially borrowing from the research on stigma reduction in the social sciences, could give us some future research strategies on how to improve attitudes.
Any other questions from the audience?
I had a question about your deviation model. So first, I was wondering why you decided to combine your control group and the obesity is not a disease, and whether if you reran the model with those groups separately, did you find the same outcomes or were they different?
Yes. So
Yeah, we thought about
we
this a
left
lot.
the stats to our group statistician, who is Kara McInnes, and she determined that contrast coding would be the best way to analyze our data. But we also ran the contrast in terms of looking at the obesity as a disease condition versus the not a disease condition, and the results were very comparable. Yeah.
Okay, we have time for one or two more questions. Anybody has any?
I have one. So this is actually going back to Sarah's question a little bit. So when you're so I teach residents in family medicine, and I'm wondering about the concept of when we position it, complexity, there does, understanding grows, and then I think that addressing that there is hope, there is tools, like contextualizing that as very important. Do you have comments that way? Like doctors often, and even young ones, brand new residents will just go, well, but nothing works. So any comments to either?
Do you mean,
that
so you mean like
have to
tools
link
for,
them?
like positive, you mean weight loss
Yes.
and success
Yeah.
story?
Yeah.
Yeah, it's hard to frame that. So you mean any suggestions that we have on how to frame that so they can understand other tools and suggestions for their patients?
Well, how much your work actually showed to that plays a big role if there's good management strategies or not, and
Yeah,
comments from
I don't think
them.
I know that just yet.
Okay.
But what I do know is that from what we've read from all the other studies that have been done in weight bias reduction interventions amongst health professionals, is that they always felt like education was not enough, and even being provided those tools about weight management and helping patients was more about how to speak to patients and communication skills and how to make sure that they're sensitive to biodiversity and having the environment be conducive to different body shapes and sizes. I thought was really important as well. So I don't know if you want to add anything about that either, but we just felt like education was not enough, and even though we provide tools on the most effective weight loss strategies that we know to date, I think it goes more than that, and I think we have to provide other opportunities for contact in addition to just educational interventions too. I'm not sure if that answers your question, but that's what we know at least so far.
Yeah.
Okay.
One quick question
Sure.
about the interesting observation you had around the views around the just world. I don't know if it showed the percentage or roughly how common that perspective is. Can you give us a sense of whether a lot of people think that way or not?
Yes. So Just World researchers would actually say that everybody has a fundamental need to believe that the world is a just place where people get what they deserve. But the people who use the scales, the researchers who use the belief in a just world scale, believe that this desire or this motivation is stronger among some people as opposed to others. And so I would say, I guess, the theorists and the researchers in that area are a bit divided, but the consensus would be that everybody has it.
So, but what about the subset that you said showed stronger?
So it was people who had stronger beliefs in a just world as opposed to, say, more weak beliefs. Yeah. Okay, thank you.
So our third presenter is Chris Ardern from York University, presenting on the association between weight discrimination and program adherence in a clinical weight management program.
Okay, good afternoon. I want to begin by acknowledging my co-authors, Jennifer Cook, Sean Morton, Sakshi Sharma, who did the heavy lifting on bringing this data set together initially, and Netta Yagana, who did the preliminary analysis. So I'm here by proxy, and I'm not a weight bias researcher. Get there. So I have no conflicts of interest to disclose. Now, as we've already heard in this meeting so far, one of the big initiatives from the Everybody Matters, the public engagement aspect of CON right now is targeting weight bias, stigma, discrimination as it relates to negative attitudes, stereotypes, labels, actions that result in social exclusion and inequity. And as we compare the prevalence of other discriminatory or stigma behaviors related to age, ethnicity, other things, we see that weight bias is quite a bit lower. It's about 10% in the general population, but it does follow the continuum of BMI to the extent that when you're in the obese class 2, about 50% of women and about 30% of men would have experienced or had a history of weight discrimination. And that's important for a variety of reasons where as we just heard nicely, the impact, the dramatic impact from a mental health perspective, individual comorbidities, as well as limitations in access to health care. And health outcomes overall, and barriers to healthy behaviors, it creates this downward spiral overall. And previous work from the Wharton Clinic on weight discrimination and weight loss goals suggests that individuals with weight discrimination histories do self-select or internalize, I should say, the responsibility around eat less, move more to a greater extent than those without a history of weight discrimination. And they also self-select more aggressive management strategies, whether or not they actually exist. And so this is actually important, again, because it creates this real disconnect. If you've got higher weight loss expectations, higher weight loss goals amongst those with a history of weight discrimination, yet longer-term weight loss success is really dictated by program adherence. So decreasing attrition in the early stages and simply attending the program overall. And so if we look at patient attrition, weight loss intervention types of models, I think we can all see that there's a potential role for weight stigma, weight discrimination as a screening tool or as a potential mediator of some of these relationships around this disconnect and overall life stress, motivation, unsatisfactory results in terms of at least the early attrition in the first couple of months of the program. So we want to explore this just a little bit further to determine if perceived weight discrimination is related to attendance at a medically supervised weight loss program and to characterize weight loss outcomes, drilling down a little bit further in terms of the characteristics of that experience. So data for this, as I mentioned, is drawn from a secondary analysis drawn from 120 patients from the Wharton Medical Clinic in Burlington and Hamilton between June 2010 and June 2014. It is a publicly funded referral-based obesity management clinic that offers personalized nutrition, medical, and activity-related programming with a variety of a team of healthcare professionals. And patients are encouraged to perform weekly self-weigh-ins, attend monthly health education sessions, and that is the standard of care, this multidisciplinary model. The exposure variable that we're interested here in terms of this broader model is simply history of weight stigma and discrimination, characterized by a very simple question: have you ever experienced weight discrimination or had a negative experience because of your weight? And then they were probed further as to when did this happen to you, types of experiences, the location of that experience, and the details of the perpetrator themselves. The outcome was a number of months of clinic attendance, and dropout here was defined as non-attendance for 3 or more months for any reason. The analysis proceeded descriptively for the most part to look at differences between sociodemographics, medical characteristics, lifestyle factors, and those with and without a history of weight discrimination by this question. And then we looked at generalized linear models to account for some important covariates listed there. So I'll jump right into the results. You can see that for the sample characteristics here, the cohort overall is overwhelmingly female. It's white. It is class 1, stage 2 obese. And the levels of activity and other behaviors, healthy behaviors, are actually above what we typically see in the general population for the most part. When we look at differences between the weight discriminated versus non-discriminated groups, we see that those with a history of weight discrimination are on average about 8 years younger. They are a little bit more likely to be white. They are about 5 times as likely to be a current smoker, have lower activity levels, and they self-select lower, or I should say higher, levels of weight expectation or weight loss. When we look at the individual relationship on a month-by-month basis, so sort of in that period, the first month or two where it would be early attrition, we see that there's actually a twofold difference in terms of the number of people who are actually in the program based on their experience of weight discrimination. So in other words, it's only significant at 1 month, but the pattern persists through about 5 months where it's equal and then reverses, in that those with a history of weight discrimination are less likely to be there and to be attending the program. When we actually pursue this, we put it into adjusted models. We actually see that there are no significant relationships. It doesn't hold. The only thing that comes forward as predicting attendance in the program longer term is actually age. But again, to address Objective 2, drilling down a little bit further, we see that when we look at the perpetrators of weight discrimination, we see that largely this is an adult, on-adult experience, so something that's experienced for the most part in adulthood. It is driven more so by men, and most of the experiences, at least in this sample, are verbal in nature. So there may be something related to those subcategories or subgroups in terms of the stigma or discrimination itself. So we're not powered to do a lot here, but I wanted to show descriptively what that looks like in terms of discrimination parameters and what you can see when it's broken down according to the when, the how, the who, and the where. You can see on the right-hand side those achieving clinically significant 5% or more weight loss over time varies quite considerably from about 0 to 35% as a proportion of each of those subgroups. So again, there does seem to be some variability here. When we look at this, though, in terms of attendance, in terms of length of time in the program, and those same discrimination parameters, nothing really comes forward as being different, with the extent of the highlighted box there of those who experience discrimination at the hands of a boss or a medical professional. And in that case, there's a twofold difference in terms of the number of months in the program. And so, I think that speaks to the lived experience, I think, of the participants, of the patients in the clinic and their weight loss journey, and the referral-based nature of this clinic, and provides some opportunities maybe to provide some additional supports. So I want to mention there are a number of strengths, I think, to this type of analysis, and it is a referral-based project, or program, I should say, but it does have a limited sample size for this type of analysis. And there isn't a complete catchment of patients. So there's response bias, self-report. So the patterns of attendance in the sample don't actually reflect the broader cohort to the full degree. We also used a single item that actually might conflate bias, discrimination, and stigma together. So it's difficult to disentangle the intensity and the internalization, I think, of the experiences there. And there's no additional stratification by responders patterns. So we might want to look at whether or not people are achieving their 5% or more pattern, and again, the extent to which they stay in the program. Finally, there's incomplete information on potential mediators, and some important ones here I'm thinking about are weight cycling, the intensity of discrimination, mental health status, and weight bias internalization. So what can we say then in conclusion, or for these preliminary analysis at least? Time in the program was not significantly, or certainly not across the board, related to weight discrimination, but adherence was significantly higher in the first month, and seemed to be different across the first few months in those with a history of discrimination, and it decreased gradually over time. And I think that further work needs to incorporate measures of weight discrimination dynamics, so perpetrator dynamics, intensity, internalization, to better identify supports and screening to ensure long-term program adherence. Thanks.
I'm really surprised about the finding that discrimination was more from adult perpetrators, because I would have thought, again, based on my own experience and research that we've done, that it would have been more in childhood. I wonder if you can elaborate on that finding.
Yeah, so part of this again goes back to the questions, so non-validated questions, and it actually conflates again all of the different experiences. So it's not asking about a particular event, it's just overall. And so we actually can't link those, although I tried to say, overall we're looking at adult to adult male experiences of a verbal nature. It's really, about, that's a point, a total prevalence overall. So I agree with you. I was a little bit surprised, and again, across the life course, we would have expected, I think, to see it more in younger people. So again, to the extent this group of people who actually said, yeah, I'm gonna fill out your questionnaires, I'm gonna participate, represents the broader clinic sample or broader experience of individuals with obesity, it's unclear, but probably a little bit different. Yeah, so actually the bulk of them were actually recruited early in 2010, and then we did another period later in 2014. So I should have clarified that. So if they dropped, if they didn't show up for 3 months after the period, they were to be dropped. Yeah, and so we'll have to go back and actually get the numbers up as well in order to look at any sort of path or mediation types of analysis that we might want to inform the theoretical models on. So they actually stayed in the program longer. I think it was 5.8 months on average.
Okay,
Okay, thanks.
Great, thank you. Okay, moving on, we're going to go to Sarah Hutchinson, who's at the University of British Columbia, and she's going to be talking about weight-related attitudes in children. Okay, thanks.
All right, good afternoon, everyone. My name is Sarah, and I'm a developmental psychologist. And today I'm going to be presenting some data that I did as part of my dissertation study at the University of Victoria. I'm going to be using the term weight-related attitudes, but just be aware that a lot of other people will also refer to this as weight stigma or anti-fat bias. I have nothing to disclose. That makes it fairly straightforward here. So I'll first start off with a few key definitions from the study. So first off, weight-related attitudes. So this refers to negative beliefs or attitudes about individuals who are overweight or obese. In terms of explicit and implicit attitudes, so this refers to either positive or negative associations that we may have for an object or person. The difference is that implicit attitudes are those that are unconscious, whereas explicit attitudes are those that are conscious and are tempered by social desirability. So why is it important to study weight-related attitudes in children? Well, I think there's several very important reasons that we've kind of heard about already, but in particular, I'd like to focus our attention on intervention. So there has been a few studies with children trying to change these negative attitudes, and they have been unsuccessful. So one of the important things for us as researchers is to make sure that our measures that we're administering pre and post those interventions are reliable. Do they have good psychometric properties? If they don't, then it doesn't matter what our intervention is doing because that won't be accurate. So that's one of the main reasons why we decided to do this study. So we had three main goals for this particular study. So our first goal was to extend previous research on explicit and implicit attitudes in children. Most research has been done with race attitudes or gender attitudes, but not a lot has been done with weight-related attitudes. Second, we wanted to test the association between two commonly used measures of explicit attitudes in children because this has not been done before in research, and we want to make sure, are these measures actually tapping into the same underlying construct? Are they measuring what we want them to measure? And finally, the fact that we're measuring both explicit and implicit attitudes within one study with a younger age group that has not been tested before was another important feature of this study. So there has been some research measuring these types of attitudes in children ages 6 and up, and in our study, we actually worked with children as young as 4. So I'll briefly describe the tasks that we used and the design of the study. So we had 84 children participate, and they ranged in age from 4 to 7 years. We used a within-person cross-sectional design, and we individually tested each child over a battery of tasks, and this took about 30 to 45 minutes, including breaks. So this is a list of the different tasks that we administered to the children, but for the sake of time and for the scope of today's presentation, I'll be only presenting the data on the explicit and implicit weight-related attitude measures. So the first task that I'll introduce to you is called the anti-fat prejudice task. And in this task, we introduced a scale to the children, and we said, look, here's a scale that has 7 boxes. And on one side of the scale, we see the word hard, and on the other side of the scale, we see the word soft. So what I'd like you to do is put these objects on the scale where you think they should go. So the children would do these test items, and once they've put all the objects on the scale, I would do a test question at the end to make sure that they understood how to use the scale. And so I would ask them questions like, so you're saying to me that you think that the rock is harder than the beach ball, right? And that's how the test items would go. All children completed these test items so that we were fairly confident that they understood how to use this scale. So when it came to the actual test items, we used these figures here, and we asked children to place them one at a time on the scale where they thought it should go. So we'd say, oh, for this scale, we see the word nice and we see the word mean. And then each figure, which was matched to the child's gender, was randomly assigned and the child would put the figure on the scale where they thought it should go. And you can see there was 6 adjective pairs there. The second explicit weight-related attitudes task that we did was called the friendship selection task. So basically, children were shown a series of images, and they were asked to simply circle 3 children who they would most like to be friends with, and then we would also ask them to circle one of the children that they would want as their best friend. In terms of measuring their implicit weight-related attitudes, we used a weight IAT, and basically this is a computerized task that asks children to respond based on the pairing of a picture and a word. So I'll briefly tell you what we found from this study. So when we think back to that anti-fat prejudice task, remember that's the one where we used the scale and the figures with the children. We found that overall, and I'll kind of walk you through the slide here, I've subdivided the sample by age, and the line indicates the data for just the overweight figure, and higher scores in this particular case indicate more positive adjectives. So as we can see, with age, children are actually assigning the overweight figures more negative adjectives. In terms of the data from the friendship selection task, which is indicated by the green color here, in this particular case, we're reporting the frequency of which they would choose the overweight figure as one of their friends. And as you can see, with age, children are less likely to, the friendship selection task is in blue. So we can see that with age, children are less likely to choose that overweight figure as their friend as they get older. And then finally, in terms of the data from the weight IAT, which is indicated in green, in that particular measure, positive values indicate a preference for the thin figure, and negative values indicate a preference for the overweight figure. And we can see overall that as children get older, they have a more stronger implicit attitudes or preference for the thin figure. And this is a rather busy table, so I'll just walk you through a few notable correlations that we found in this data. So we found that with age, as I mentioned already, there was a strong association between age and implicit weight attitudes, which is circled in blue there. We also found that there was a strong gender difference on the anti-fat prejudice task. So we found that girls were actually more likely to give more negative adjectives to overweight figures compared to boys. And then finally, most importantly, we found that those 2 measures of explicit weight-related attitudes were significantly associated, suggesting that they are tapping into a similar underlying construct. I'll skip over this hierarchical regression just for the sake of time and move right into the discussion and kind of a summary of our key findings. So basically, we found that both explicit and implicit weight-related attitudes increased with age. And as I already mentioned, those 2 explicit weight-related measures were associated, and girls reported more explicit weight-related attitudes than boys. So I think this study has several both theoretical and clinical implications for research and practice. So research over the past 5 decades has shown that we have this preference towards the thin figure. And these preferences have been linked to discrimination. So despite this, we know very little about the factors that are related to how these preferences develop, especially at a very young age. So only a few studies have really explored this, looking at parent attitudes or perhaps the influence of the media. So for example, one study looked at content analysis of children's cartoons and found that there was a relation between exposure to kind of bad characters that are overweight and those types of negative attitudes. Thanks. But what other factors are missing? What else do we need to explore to better understand how do these preferences develop? Because we have this gap in our knowledge, addressing weight-related attitudes is an important part of both obesity prevention and treatment. So previous interventions to reduce these types of attitudes have kind of focused on attributions or personal responsibility, which may in fact actually reinforce these negative attitudes towards those that are overweight. So instead, a better solution might be actually teaching the value of diversity and difference, so that would reduce the risk of further stigmatizing children and adults. So what kind of message can we tell to clinicians, to parents, and to teachers? Well, just to have an awareness that these preferences are becoming stronger with age, and be careful about the language that you use with children, because they are sponges, as you probably know. And another really important message is to not blame the child or the person or the adult who is overweight, because there's tons of research, as I'm sure most of you are aware, that these types of negative blaming messages actually further stigmatize people and lead to poor outcomes in terms of encouraging healthy lifestyles. So I'd like to just conclude with a few acknowledgements listed here, and thanks for your time and attention.
Any questions?
Well, I have one.
Okay, great.
Has anybody done the work on parents and children to see if there's any correlation there? And I guess the second question around that is, so where are the attitudes coming from? They're coming from, I guess, everywhere.
Yes.
So what else can we do?
Sure. So to address your first question, which was about is there a relation between children's attitudes and parents? And yes, there does seem to be a relation. Some research has found that especially the attitudes of fathers can be highly predictive of adolescent girls, which is very informative. So just having that knowledge and awareness and educating the parents to use person-centered language and appreciating diversity in body size, I think is an important message that will then get passed down to children. And then your second question was about...
so the attitudes, where, we know that these attitudes are held widely. And
yes.
Yeah, so do you have any kind of sense of which is the strongest? Is it from family? Is it society, school, peers?
Yeah, I think they all kind of combine together. Though I think there's research in other areas of attitudes and stigma that I think are applicable for weight-related attitudes. So they found that in terms of changing implicit attitudes, which are those unconscious attitudes, in research related to changing race attitudes, they found that by presenting counter stereotype examples, so showing an African woman that's very smart and articulate can have an effect on those implicit attitudes. So one potential avenue for future research is to explore that. If we can provide those counter stereotypical examples, will that change people's attitudes towards people who are overweight in general? Yes.
Any other questions? Can I just ask one more then?
Sure.
Which is, how did you find those scales with children as young as 4? Because that's pretty young to be...
Yes.
Yeah. And would you change them?
Mm-hmm. I think the scales were pretty good in terms of they were very visual, so children were able to understand them. However, I must say that one thing that I didn't get to mention during the presentation is for the weight IT, the computerized task was particularly challenging for the 4-year-olds, just because they don't really have that fine coordination in terms of button pressing quite yet. So we did find that some of them weren't able to complete the task. But I think there's still a lot of work in terms of developing better measures, especially those that are child sensitive and child appropriate. Thank you.
Thank you.
Does everybody just want to stand up for a minute since we're halfway through and stretch your legs? So it's Ava, you're up next. Come on up. Stretch, big stretch. Okay. So next speaker is Ava Pila, who's from the University of Toronto, presenting The Weight is Even Worse Than the Cancer, exploring women's psychosocial experiences with weight after treatment for breast cancer.
Awesome. Awesome, thank you so much. So just before I get started, I would like to thank my collaborators on this project from the University of Toronto and Women's College Hospital. And so today I'll be presenting a part of my dissertation work at U of T. So before I get started, I'd just like to note that I have no commercial conflicts of interest to declare. So in Canada, 1 in 9 women will be diagnosed with breast cancer in their lifetime. And so luckily, due to our very significant advancements in screening, prevention, and in treatment, we have a large portion of the Canadian population of women that has much more improved survival rates. So the 5-year survival rate for breast cancer is sitting at about 88%. But this presents us with another challenge. So now we have a considerable portion of the female population in Canada which is dealing with the side effects, both psychological and physical in nature, that are caused due to the side effects of treatment for breast cancer. And so one of the most commonly cited side effects that a lot of women tend to experience is a treatment-related weight gain and a change in body composition as a result of the myriad of cancer-related treatments. And so we see a large range of percentages, but the most commonly accepted are that about 50 to 96% of women treated for breast cancer experience some sort of weight gain. And this is even more complicated by the fact that over half or over 65% of women with breast cancer also experience excess weight and a history of weight cycling pre-diagnosis. So we can see that there's a pre-cancer association as well as a treatment-related association between weight and breast cancer. And so this tends to be quite problematic because excess weight has been shown to be linked with a higher risk of cancer reoccurrence, higher psychological comorbidity, and also worsened cancer-related mortality. And so because of this really complex and strong association between excess weight and breast cancer, we see that weight status and weight gain is associated with psychological distress. So about 80% of women report feeling considerable dissatisfaction with their weight and their body composition as a result of cancer treatment. And in fact, there's been several studies to suggest that weight gain and this change in body composition is actually the worst side effect of treatment above and beyond other side effects like nausea and fatigue. And what's even more problematic is that this weight-related distress tends to be reported as many as 3 years and more after the post-treatment phase. So again, this tends to be the more chronic issue in that survivorship trajectory. And this is complicated by the fact that a pre-cancer weight history tends to exacerbate this weight-related distress, and that these weight-related concerns are quite stable for women across older age as well. And so the current body of evidence is quite limited in this regard. There's very few qualitative accounts to understand women's weight-related concerns. And to date, these accounts have really focused exclusively on women who have gained weight post-treatment. However, we know that weight preoccupation, or the psychological distress associated with weight, is actually much more important than objective changes in weight. And the current evidence right now has shown that there's a subset of women who may be particularly at higher risk of experiencing the psychological consequences associated with weight gain, and that this sample really needs to be examined. So that brings me to the purpose of this study, which was to examine a sample of weight-preoccupied women who have been treated for breast cancer, and to just really try to understand the in-depth experiences, their interpretations around their weight-related changes across the cancer trajectory. And by that I mean considering their experiences pre-diagnosis to currently about 5 years into survivorship. And so participants in the study were purposefully sampled from a ongoing prospective longitudinal cohort study. And so in the study, we sampled 11 participants who had expressed weight preoccupation post-treatment, and who also had expressed year-long anxiety associated with their weight. And so they were in a trajectory of increasing and stable of concern regarding their weight. And so the sample in this qualitative study is quite typical of the sample of women in Canada with breast cancer. So looking at about a mean age of 66 years old, mostly postmenopausal, early stage diagnosis, and most have a history of weight cycling, so about 55% in the sample. And actually, we have less than half the sample, 45% of the women, that actually reported quite severe and debilitating depressive symptoms. And this is not always diagnosed, but based on some cutoff scores from a range of years' worth of research that we have with the sample. And so the procedure for this study was a one-time semi-structured interview that was about 90 minutes in length. And the interview guide really just tried to be as flexible as possible, let the women be the guides in defining their experiences and explaining the meaning of their experiences. And because of this, we used an interpretive phenomenological analysis, which is very iterative, very person-centered, and really just tries to highlight the lived experience of the individual in question. And so here we have just a brief overview of some of the themes that emerged as a result of this project. And so a lot of these themes really center around this idea that women's weight-related concerns and weight-related preoccupations were quite distressing to them. And this was, again, in that 5-year survivorship stage. So I'm going to be discussing each of the themes in more detail now. So the first theme was that women described this intense history of weight cycling. And so this was much prior to their cancer diagnosis, across their adulthood years. And they also described an ongoing quest to manage their weight. So we can see these experiences being described by Susan, who's a 71-year-old breast cancer survivor. She describes being obese, as she calls it, pretty well all of the time. She's still considered this way. And she would describe sort of this mood-related change between her weight. When she would lose weight, she felt really good. When she lost weight, she would feel very defeated, as she describes it. And then she also describes that despite all of this, despite this weight cycling history that she's experienced throughout her life, she's still determined that one day she'll be able to get that weight down. Similarly, Elizabeth, another survivor, describes that she's always had this concern. However, Elizabeth also describes that she participates in a lot of exercise, she manages her diet, and still this is something that she's grappling with. In the second theme, women describe these perceptions of failure around their weight management behaviors. So this is something that we've heard since the beginning of the conference, but now we'll be able to really understand it in this contextualized sample. So Lynn describes being very observant about what she eats. She describes a situation where even on her birthday, when someone will buy her an alcoholic drink, she'll pass it away because she doesn't feel comfortable. She wants to expend some energy on her diet, and she doesn't feel comfortable doing that because she is concerned about her weight. So we can see these very intense experiences where weight is trying to be managed. Vanessa describes an example of how she feels consistent failure around the fact that she can't understand why her weight can't be controlled. She tries everything. She feels like she's a very strong and resilient woman, yet this is the one thing that she really can't grapple. So again, these very intense experiences of preoccupation with the weight and failure around any effort to actually manage the weight. As Susan then describes that it's very similar again to Vanessa, that she can't understand why. She finds it extremely stressful dealing with the weight while also knowing that it causes her or it contributes to her reoccurrence of breast cancer. So again, this concern is really exacerbated by the fact that these women know that the excess weight is detrimental to their cancer outcomes. So they feel that sense of blame. We also see a shifting psychological impact of cancer versus weight. So Susan describes that during that acute cancer diagnosis and treatment phase, you really don't have time to think about the weight. You're worrying about not dying, as she describes it, and the cancer killing you anyway. So really, you're concerned much more about the weight years down the road. Elizabeth describes a really interesting account where she felt actually that keeping her weight kept her secure. It was her security blanket. It kept her thinking that her cancer would be kept at bay. So again, this is sort of similar to some victim accounts of sexual assault, where the excess weight tends to be a protective factor. And Vanessa describes I think a really interesting account where she says she blames a lot of the outcome of her weight to her diagnosis of cancer. And so here she says the weight is even worse than the cancer sometimes. And so just really quickly, I'll also describe some internalized and explicit social pressures around weight loss that these women describe, always in the context of risk reduction. So Linda describes that she's put that pressure on herself to manage her weight. Meanwhile, Sophie and Susan describe that typically their experiences of social pressure or weight stigma are around the healthcare setting. And so Sophie describes that she's very afraid to get on the scale when she goes to her physician's office. She's afraid that she's going to get blamed for putting on weight. Susan then describes taking more considerable efforts, like taking laxatives before her medical appointments, weighing her clothes, and wearing body shapers to hide her rolls. And overall, I think the findings from this study are really encompassed by this theme, is that women's weight-related preoccupations are really contributing to their worsened mental health. And so we can see a few examples of this above. And just in the interest of time, I'll just cover the implications of this work, which really we need to understand that we need to consider that women's weight histories pre-diagnosis just as much as we consider their treatment-related changes in weight. So again, we need to consider women's entire histories around weight to be able to understand their personal experience and help them through the survivorship period. And quite interestingly, the women in this study described cancer as this acute and fleeting event that could be treated, whereas weight preoccupation was what was chronic and enduring and very difficult for them to find a way to treat. And so we really need to understand how we can target these experiences and improve the psychological functioning of women in their treatment-related outcomes. Okay, thank you.
Is this working? Testing. So, Ava, thank you for doing this work. So again, being a family practice physician, we see this now as a huge problem. And I was just wondering if in your work, if any of the women brought up that they would have liked to have been warned and maybe empowered more about prevention and understanding. Did that come up?
Not as much so in the context of the diagnosis of breast cancer. Mostly, I guess, the women's descriptions were around just treatment. So yeah, not as much in the prevention side. So
no, I meant about weight gain, preventing the weight gain that would come, not the cancer.
Okay,
yeah,
right,
like they
yeah.
wish they
Yeah.
now 5 years later they're often saying, now that I have this better understanding of the disease, I wish I could have.
Yeah, they definitely described feeling a need to understand strategies, but I mean, really most of the sample described that they were engaging in exercise, they were managing their diet, so they were actually putting forth a lot of the typical efforts that are prescribed, but these efforts were unsuccessful, and really it was just the failure associated with not being able to see any weight-related outcomes as a result of all of their efforts that was very discouraging. Yeah, that's a good question. So most of the women described that they would like to have actually gotten more sort of assistance with or discussion around their weight and mostly around their psychological distress associated with their weight. And then several of them just described the more negative experiences that they've had in oncology practitioners and in their general practitioners now later on. But so that was really all that we saw, yeah.
Okay. All right.
Cool, thank you.
Okay. So moving on to our next speaker, I'd just like to introduce you to Aurélie Bayot, I hope I got that right, from the Université de Quebec. and she's going to be talking about the impacts and determinants of excess skin after bariatric surgery, a scoping literature review.
No. Okay, it's okay. I'm very happy to have the opportunity to share with you the results of this scoping review about a topic that is very important for me because it's provide from patients' concerns. And I have no conflict of interest to disclose. And I have a question for you. What is it for you? Probably, I think it's just a very cute sharp puppy. But for me now, when I see sharp puppy, I think about my patient that told me after bariatric surgery they look like sharp puppy. And probably they told me that not because they think they are cute. So I will start. As you know, bariatric surgery offers large benefits in individuals with severe obesity, massive weight loss, health and quality of life improvements. For these reasons, the number of bariatric surgery had remarkably increased during the last decades in North America. Despite these benefits, individual may be dissatisfied with results of bariatric surgery, and given that we have more than 70% with excess skin after bariatric surgery, a growing number of researchers have investigated the impact of excess skin after bariatric surgery. They reported that excess skin can cause psychosocial, physical, and daily living challenges, and that's why we need now to synthesize the current knowledge and the impact of excess skin experienced by patients. Excess skin after bariatric surgery can be removed only with plastic surgery, and although 70 to 80% of patients would like plastic surgery, only 10% finally undergo plastic surgery. So a lot of patients have to live with excess skin. That is why we need to know what are the factors that can be associated with excess skin inconveniences and excess skin quantity to inform the development of intervention to targeting high-risk people to help them to deal with excess skin. So this scoping review aimed to identify studies focusing on the impact of excess skin experience among adults with after bariatric surgery, also to determine the correlate of the quantity of excess skin, but also the excess skin inconveniences, and identify gaps in the current knowledge. Studies were included if they were primary research in peer-reviewed journals, if they included adults who had undergone bariatric surgery, also if they assessed the impact of excess skin experienced with patients, or have data on correlates of excess skin quantity or excess skin inconveniences, and if they were available in English or French. PubMed, Signal, and Psychology were used to search relevant studies in May 2016. And we use keyword referring to excess skin and also mainstream referring to bariatric surgery. And title and abstract, then full text, were screened by 2 independent reviewers, and a third reviewer without disagreements between these 2 reviewers. What we found after screening title and abstract and full text, we finally include 24 studies with 11 qualitative studies and 13 quantitative studies. The vast majority of studies are recent, so they were published after 2011. Only 2 studies were prospective. More than half of studies were conducted in Europe, and a total of 2,380 adults with a mean age of 44 and a majority of women and a majority of gastric bypass surgery were included in this review. And all the subjects were recruited at 12 months after bariatric surgery or more. And as you can see, there is a large range of recruitment timing. What we found is that this figure shows the number of studies who reported psychosocial, physical, and daily life impact of excess skin after bariatric surgery. Psychosocial impact emerged in 91% of qualitative study and in 55% of quantitative study. The subject in this study reported embarrassment due to people staring, also body image dissatisfaction, low self-esteem, depression feeling, shame. And for physical impact, it was reported in only 55% of qualitative study and 77% of quantitative study. Physical issue reported by patient was skin problems, also flapping, wobbling, heaviness, pain, bad odor, and that's totally. And for daily life impact, there was more. It was more studied by qualitative and quantitative study compared to psychosocial impact. And what patients reported, it was like their mobility limitation. Also, they declare more inconvenience during physical activity, during daily life activities. Also, they have itching problems, difficulty to be naked in front of other, difficulty during sexual relationship, and also difficulty to find clothes. However, there is no evidence whether psychosocial, physical, or daily life inconvenience function was most affected by excess skin. We don't have prevalence data, or if we have this kind of information, that is very different between studies. So we can't say what is more affected by excess skin. Concerning the correlate of excess skin, on the 13 quantitative study, 9 reported association or correlate. The 9 reported association with correlate and excess skin inconveniences. 78% reported correlate between self-reported excess quantity, and correlate, and only 3 studies have data and association between correlate and objective measure of excess skin. We found anthropometric, psychosocial, sociodemographic, surgery-related, and behavioral correlate. And what this study found, all the studies are agreed to conclude that women reported more excess skin quantity and excess skin inconveniences compared to men. But we don't know if they really have more excess skin quantity. Neither pre-surgery BMI, time to surgery, nor type of bariatric surgery were significantly associated with excess skin inconveniences. But we don't know for excess skin quantity because for all the correlate, there is no evidence because of inconsistency between studies or limited number of studies. So what we know, finally, we know that excess skin can attenuate the benefits of massive weight loss. It seems that there is difference between sex. Women are more affected by excess skin. What we need to know, a lot of things, but to be short, we don't know what is the prevalence of participants experience impaired psychosocial evaluation of excess skin and inconvenience after bariatric surgery. Who is more likely to have higher excess skin quantity and to report more excess skin inconveniences? Are excess skin inconveniences, excess skin quantity, objectively measured or self-reported, associated together? We don't know. And what we identified for a researcher, we really need now well-designed multi-center prospective study, also to study in greater depth, sociocultural, psychosocial, and behavioral variables. Also, it will be interesting in future study that they systematically couple objective and self-reported measure of excess skin And it will be good that they use better tool to measure the impact of excess skin and excess skin quantity. Application for practice, it's very important to inform patients of the impact of excess skin. I think now we know that there is impact, so maybe inform patient will be a good idea. And it's also important during follow-up that the excess skin should be assessed or at least discussed with patients to provide adequate support, but we don't know what is adequate support. There is no evidence about that. So in conclusion, more studies are needed to understand the moderators and determinants of excess skin quantity and inconveniences in order to improve healthcare provided to patients before and after bariatric surgery, and to offer intervention targeting multiple factors. I strongly believe such research will provide evidence of the need to provide additional follow-up to patients and need to stop the obesity epidemic. It's not enough to intervene in such way to produce weight loss. We also need to ensure that people who undergo weight loss can benefit fully from the weight loss. Thank you for your attention. I just want to finish by thanking all the collaborators and the Université du Québec en Outaouais for the startup award grant. And thank you for your attention, and sorry for my English. I tried to.
So your English is better than my French. So
Yes, but
any questions?
oh.
I'm new to this literature, so thank you very much. Are there any interpretations of why 80% of people would like to have surgery, but only 10% do?
Yeah, there is, I think there's several reasons. The first is financial issue. And after some patients want to, but it's again another surgery with potential problem. So sometimes they just say, no, I don't want to go through another surgery. So I think that's financial reason, or it's because they don't want other surgery, but also maybe they may be afraid of that.
Can I ask a follow-up?
Yeah.
For those people who do have surgery, are they generally happy with the results? Does it tend to be a positive experience?
Yes. It's very important to understand that if they have choice and if they know that how they look like now, they do the same thing. Yes, of course, they do bariatric surgery. They are happy. They are great improvement in quality of life. But it's just like sometimes they're dissatisfied with that. And before surgery, it's like they have weight that was a barrier to do some stuff. So, but after there is excess skin. But when they have their clothes, they look like better. So they don't have to. I know some patients that don't want to lose more weight, and some patients that eat more because they, yes. But I think it's very, I don't know the exact prevalence, but it's not a majority of patients. But yes, I know one patient that eat again to gain weight because of excess skin.
Really interesting. Thank you.
Great talk, thank you. I'm just wondering if you retrieved any French studies, and if you did, were there any differences in terms of outcomes between the English and French trials?
We don't have this kind of data. No, I don't know, but probably yes, it will be. It's like social pressures may be different with the culture, but I was surprised to find that most of studies were conducted in Europe, because in North America, I think we have a lot of bariatric surgery, so I was surprised. But there is a team of researchers in Sweden that work a lot of the subject. That's why we have more study in Europe. But between English and French, I don't know, but it could be interesting. And I live in Gatineau, so just close to Ottawa, but maybe I can study this kind of.
I does make me wonder, though, we didn't get a great deal of there's so many challenges we've already noted with the report that came out yesterday that is this another thing that we need to add on to that as just access to this kind of surgery, post-bariatric surgery? And is it something that we should be lobbying to get funded through public funding?
I don't know the answer, but because for some people, they can have access for free for plastic surgery because it's like not aesthetic issue. It's like, for example, they have irritation or infection, so that can be reimbursed. But I think, in my opinion, yes, but it's just my opinion, because I think for some people, physical health and psychosocial health is also important. So yes, maybe, or maybe we have to propose intervention to help people to just improve their body image, body satisfaction. And before surgery, we maybe have work to do, and maybe they will be more happy with excess skin after bad surgery. So I think yes, but where is the limits? Yes, where is the aesthetic and health? And I don't know, so I don't have the answer. So.
Thank you. Yeah, I think we're out of time, but Ted, you are actually the next speaker. So.
I just wonder if there's an objective way to differentiate between how reconstructive surgery is handled after mastectomy versus how this is viewed. Is there a possibility of an objective comparison between those policies? I can ask you after this. Sorry.
If you want to come on up. So our next speaker, Ted, you can come on up, is Ted Kyle from Conscience Health, who will be speaking variation in biases about obesity and people with obesity in Canada, the US, Mexico, and Brazil.
Thank you so much, and I want to thank the organizers of this conference, the hardworking organizers of this conference, for putting together such outstanding content and bringing together such a diverse audience of people. I also want to thank my collaborators, including one of those hard-working organizers of the conference, Jimeno Ramos-Salas, Bruno Halperin, Natalie Dumas, Joseph Naglowski, Leo Wiggum, Diana Thomas, and Rebecca Poole. Disclosure, I have consulting fees with these companies. The program received support from the Obesity Action Coalition, which is a nonprofit, to defray the costs of the research, and the Obesity Action Coalition receives support from Novo Nordisk, which helped to make this research possible. We could not have done it without that support. In terms of mitigating potential bias, we are not discussing any commercial products or programs here, so I don't feel like we have any bias to mitigate other than weight bias. So for background, there are competing narratives that have been written about for thinking about obesity and what sort of problem it is. One very common, certainly in the United States, it's also common in Canada, is the narrative of moral failure. People viewing obesity as a disgusting failure of personal responsibility. And then more recently, there's been attention to obesity as an addictive disorder where people become hooked on junk food and sugary drinks and can't help themselves. And then there's the view of obesity as a function of a toxic environment with too much unhealthy food and an environment that makes exercise impossible. And then finally, the medical narrative, which we heard earlier on as a narrative for viewing obesity. Pervasive weight bias, I think, as this group knows all too well, hampers clinical care and obesity-related policy. Dr. Kirk, I quote you in terms of how unsupportive the system is. And it actually contributes to a very dysfunctional medical dialogue. Weight bias compounds the harms of obesity, where you have a health impact from the disease, you seek health care, you encounter weight bias, and that leads you to avoid health care, which then leads to more unhealthy behaviors and worsens the problem of obesity. A few key elements, and these feed into our methods of weight bias in this study, are blame directed at people with obesity, and that was discussed earlier in this session, and assumptions about people with obesity that these are people who are lazy and lack self-discipline. And then there is the issue of social rejection, which we heard in some of the data that was presented. So our objectives were to look at public attitudes in Canada, both English-speaking Canada and French-speaking Canada, in the U.S., in Mexico and Brazil, and assess differences in how obesity is viewed, and assess explicit beliefs about people with obesity, and look at the differences among the countries surveyed and the French and English-speaking cultures of Canada. How we did this was through web and smartphone samples via Google consumer surveys. We talked to a total of 47,282 people in the fourth quarter of 2016, and this is how it breaks down between the different countries and cultures that we surveyed. The reason the numbers are so large is because each respondent answered only one of the 18 questions that we administered, and this was to avoid fatigue, especially when you're talking about a subject like weight bias. People tend to guess as they progress in the survey what you want to hear from them, and so they start giving you less candid responses just to get rid of this survey. I will mention that the way that this pops up is when you are looking to access premium content on the web, they will serve you this question. They say, if you want to continue reading this content for free, just answer a quick question, and then you can go on your merry way. About to push the wrong button and get myself in trouble. We used 5-point Likert scales. We assessed 4 different narratives about obesity causes. We assessed some explicit measures of blame, social acceptance, laziness, and self-discipline. And on those questions, we asked each question in both positive and negative form. And in particular, we found that that's important in the Spanish culture because Spanish respondents are agreeable about more things. So you get the answers skew higher on both forms of the question. We got a minimum of 500 respondents for each question in each country and language. So the results. The one thing that stood out, and I'll be presenting some results from European cultures as well next in a couple of weeks at the European Congress on Obesity, is that there's a really strong belief across cultures that obesity results from addictive junk foods. And the group at the Rudd Center has done some research on the stigmatization associated with this narrative of addictive junk food. Interestingly, and I would recommend reading some of that research. But in particular, it was strong in Brazil, where 44% strongly agreed that this is what obesity is about. It was also especially strong in French-speaking Canada and stronger in French-speaking Canadians than in English-speaking Canadians. And I can only suppose about the reasons for this difference, but just in the patterns that we've seen elsewhere in places where one has the sense that there's a strong cultural value on food and cuisine, there is a stronger identification of addictive junk food being the evil behind obesity. And then the flip side of this is that in Brazil, which had the strongest agreement with addictive junk food, we saw the greatest doubt that irresponsibility was the cause behind obesity, and this was very striking. You had 35% of respondents strongly disagreeing with that assessment. Contrast that with French-speaking Canadians, where they were not quite so generous, and in the U.S., the assessment of that has not been in the past quite so generous. Also in Brazil, in these explicit measures of blame, we saw less assignment of blame for obesity to the people with the condition, and you saw less assignment of blame by French-speaking Canadians than English-speaking Canadians. Finally, we saw more social acceptance expressed by French-speaking than English-speaking Canadians. In this measure, would you be willing to interview a person with obesity for a job? We also asked, would you avoid speaking to a person with obesity? Would you mind if a person with obesity married into your family? So, conclusions, and to wrap up and leave some time for a couple of questions. Public beliefs related to weight bias really do differ markedly between these 5 populations. The belief that addictive junk food causes obesity is strong, and in Canada, French and English-speaking populations definitely hold different views in some ways, and we intend to track these patterns to help guide future efforts to overcome weight bias. And just for more information, you can find it here on the internet, and these slides are available to you to download at this address. Thank you very much.
Okay, do we have some questions? Have time for a few questions for Ted?
Yes.
I'm not familiar with this method of collecting data. Do you get any demographic information, like what's the age range of the respondents?
We do. We've published a couple of studies using Google consumer surveys. They do, just as they do for selling advertising, use inferred demographics rather than explicitly reported demographics based upon browsing history and so forth. They have done studies to look at that, and that's a natural question. Is it more accurate to look at their behavior to see what their income level might be, or to have them rely upon what people tell you about how much money? And in aggregate, it's pretty much a wash, whether it's inferred or explicit demographics. We do get that. We don't get racial and ethnic demographics. We do get language. Have age, we have inferred age, we have gender.
Was there any comment on gender differences, like particularly Brazil?
Well, in general, and I don't have the numbers in front of me, but it's fairly consistent that we see more bias expressed by men. Yes?
I'm new to this data collection technique as well, and I'm just wondering, does the survey pop up for people depending on the browser history, or is that 1,000 people that were on the internet that day?
They do recruit a balanced sample for you based upon the demographics to be projectable to the population that you're sampling. So, for example, in 500, I will get close to 400, 450 with inferred demographics that allow projection to the population.
So Google's commitment is to try and randomly distribute the questionnaires? Or to select for, I'm just wondering, for instance, if people who were searching for weight loss, exercise, diets were more likely.
They do not tailor it to the content of the questionnaire. They do make best efforts to give you a demographically balanced sample, and you get statistics on sampling error. Yeah. Other questions?
I do.
Sure.
I'm really curious about the junk food addiction question that you had in there, and particularly around, do you think there's anything, I mean, we know that there has been a sugar tax, a sugar sweetened beverage tax in Mexico, I think it was.
Right.
Yeah, do you feel that that's played a part in any of the...
In Mexico?
Yeah, in the responses from Mexico, was that I can't remember when that came out.
So it's possible. It's also possible that the agreement that we see with those narratives is a reflection of the inclination of Spanish speakers in Mexico to be more agreeable about stuff that you put before them. And I could not come up with a good way to state a narrative in both a positive and a negative. You know, it just doesn't seem like that's very doable. But if anybody has any ideas, I'd love to hear them.
Okay.
Thank you.
Thanks. Okay, so we move on now to our final speaker. So this is Denise Campbell-Shearer, who's going to be presenting on There's a Reason Why You're Overweight, Perspectives of Adults Living with Obesity on Barriers to Treatment.
Thank you. Everybody up. Stretch. There's only one more. Stretch. No, great. Yeah, sorry, my apologies. I'm zipping between rooms because these concurrent sessions when there's cool stuff in different places. So I'm not offended if you rush out to the other room because it's cool too. Where's the little thing you make it go forward? Ted? Oh, okay. Anyway, I'm tickled to be here and to get to present a little bit on some of the work that we've been doing on our patient qualitative sub-studies. This is a quote from one of our participants in the study. And should first of all acknowledge the team who were working on this particular part of the study. And in terms of disclosures, the funding for this particular piece of work was from Alberta Innovates Health Solutions with significant in-kind support from our partner, the Edmonton Southside Primary Care Network, without whom nothing would happen. Otherwise, that's my disclosures. So the content of this is got nothing to do with anything commercial, so there should be nothing to really mitigate. So just a word about the program. So I'm a family doctor, and we've been working for about 4 or 5 years, I guess 5 years now in our group, around trying to change practice in primary care. And so we know that there's a huge burden of problem out there with regards to obesity, and we also know that primary care providers are really ill-prepared to be able to help patients that come to them for help. And so our goal as of the whole program is to try to improve the quality of care. And to that purpose, what we've been trying to do is a series of work where we've been doing participatory approaches with the community to get out there and to try to understand from the provider's perspective, interdisciplinary provider perspective and team perspective, where do they have struggles with regards to being able to help people? What do they need to know, or what do they need to have differently in context to be able to help better? And we're also interested to know from people's perspective who are living with this condition, what do they need? What do they want? And we sort of feel that this fits in the whole puzzle because it's this huge overlapping picture where you have public health and all these different interventions. Ultimately, though, the relationship that you have with your primary care provider can be a pretty intimate one. And you can have that relationship over your whole life cycle. So there should be capability to be able to provide that to be a helping place rather than a hurting place. And I think comes down a lot to capabilities. So we really wanted in this project to explore the patient perspective in our context. So the place where we've been working is the Edmonton Southside Primary Care Network. It's an affiliation of around, I think now, 275 family physician practices in South Edmonton. So we serve 300,000 patients. And we have interdisciplinary teams embedded in practice with nurses, dietitians, mental health workers, respiratory therapists, a whole lot of folks to try to deliver enhanced primary care. And we also provide a certain amount of programming as well, some of it around weight. But what we were finding was that providers, despite the fact they'd had training, weren't actually doing this work. They didn't feel comfortable and confident. So part of the program was to try to increase that. And the other piece was we wanted to know from the people that we were serving, what was their experience of the care that they were getting from us? What did they want? What were they getting that they liked? What were they getting that they wanted more of or less of? And what did they think about different ways to do it? So that was the impetus for this project. So we have a cohort of patients, about 232 patients, who we were just following in an observational way over time, who were experiencing care in our context, and we were collecting data about them. And we also consented them all to be approached for further studies. And so we were able to select a group of them with pretty diverse characteristics for this project, and interview them and ask. So it was semi-structured interviews, followed, standard methods for analysis. And these were the characteristics of the folks that were in the group. So you can see we were able to get a pretty diverse group of people. Still more women than men, which matches pretty much what you see in primary care usually. Predominantly Caucasian in this particular group. Good range of different incomes and medical comorbidities and ages. So the data that I speak to today is really just about people in this context. So what we really learned, I think, from the stories that the people told us about their experiences was very much, to quote the patient, there's roots, there's reasons why you're overweight. They really echoed a lot of that narrative that we see in the 5A's work from the Canadian Obesity Network around the 4 M's of obesity. So they talked a lot about their journey with different comorbidities, with different contextual factors in their lives, with different things that had contributed to their story of how they had developed problems with excess weight and how that had resulted in harms to their health and challenges to their health in terms of their function and the way they wanted to live in the world. And we really saw that that narrative was really important in terms of their ability to access care and how that all ended up moving forward. In terms of themes around the specifics around what did they want and what were they getting, there was sort of 4 things that emerged. And the first was the importance to them of the patient-physician relationship. And they used that term. They talked about their family doctor, as well as their teams, but predominantly their family doctor. And what they really said was they had an expectation that the family doctor would initiate the conversation, that they would do so from a perspective of being effective, knowledgeable, and beyond all else, kind. So this theme of careful and kind care came up a lot. The second thing was that they really wanted a coordinated whole person approach to address this whole complex story, these multiple conditions that drove their personal experience with obesity. They did find that the existing services that we were offering within the primary care network were good. They liked them. They loved the team members and the courses. And it was meaningful in terms of providing, some people felt that sense of accountability, that sense of community, that there was elements of that were helpful to them. But the big complaint that they had was that they really wanted care that was personalized to them. So they could go to the weight management course, which they really liked, which was very holistic and focuses on health and stuff like that. But it's kind of giving the same message to everybody, and they really wanted something tailored to them. So a few quotes, just in terms of patient-physician relationship. There was a proportion of patients who had, as Canadians experience, only a quarter to a third of patients report ever in the history of their relationship with their family doctor having any conversation with them about anything to do with diet or exercise or weight or anything. And that came out in a proportion of the patients. Some of the other patients were commenting on that importance of that, the conversation, and that they really wanted to have that. In fact, they actually equated it with quality of the relationship, that if you were really concerned about me, you'd initiate this conversation. And what we really want to go for is quotes like the one in the dark yellow, which is a really integrated, person-centered approach where it's integrated in terms of their whole experience of their health journey. So that's kind of the primacy of the relationship. In terms of coordinated whole person care, one of the things we had learned and which we've been trying to work on a lot in context is the importance of having a team approach where we're giving consistent messaging and we're able to pull things together for people in a way to help them come up with a sensible action plan that they can use in their life. And we were seeing that kind of messaging in the sense from patients saying that they really felt that when they were talking to their dietitian or they were talking to their family doctor or they were talking to the mental health worker, that they were getting consistent messaging. And that was really helpful because we know that if patients are getting different messaging from different professionals, it really creates challenge for everybody in the role. So where we're going from here based on what we've learned, and actually it was interesting, everybody said in one format or another that they really wanted that personalized element. So where we're going with that right now is actually we've got an idea of how the intervention could run out in primary care practice, the personalized intervention. So we're actually videotaping patients now and then interviewing them around the quality of the consultation, interviewing the provider, and then actually having them journal in the community around how that's impacting their life. And we're re-interviewing them every month or so to try to understand what is it? When they say personalized intervention, what does that mean? What is that? How does that actually translate into clinical action? So that's kind of where we're at right now. So thank you so much.
I'm going to take chair's prerogative and ask the first question before I ask anybody else if they have one, because this is really interesting to me.
Okay, so I'm really nervous because I read everything you write, so. And I'm like the equivalent of a third-year undergrad qualitative researcher, so I'm feeling sweat, I'm feeling stress.
I'm fascinated because actually one of the things that we found in our research was around that issue of support, and the fact that, so we had this kind of, the feeling of people feeling that they were wanting support, but the healthcare providers were worried that they would become dependent on it. And I'm just curious to know if you found anything like that, because I think that was, to me, one of the really, really fascinating things about the study that we had when we trying to look at those sort of tensions that exist.
Mm-hmm. I thought there were so many fascinating things about the study you're talking about. I don't know that I can shed light on that particular point. I think for me, when I think about this as providers, the family docs right now in Canada are having to talk to patients about physician-assisted death. We're talking to patients all the time about bad diagnoses, walking them through palliative care, walking them through all sorts of awful things in their lives. So I think sometimes we don't tend to say to a patient, we're scared if you come see us every 6 months for your diabetes, you're going to get dependent on us. So I almost wonder if some of those narratives aren't coming from a place of fear and not actually having an effective approach. And I actually liken it to depression 30 years ago. So 30 years ago, people didn't want to ask people about suicidality because they were scared that they might kill themselves. Now, people know how to do that work. Even a young med student will know how to do a basic assessment for depression, and they'll know how to assess for homicidality and suicidality and risk. And it's because they've learned how. And I think what we haven't done in this space is we actually haven't taught people how. And I'm not even sure that we even know how. And that's where I think we have to take from a primary care space where it's brief consultation, something quite different than a psychologist. I mean, Rena's sitting here, and I know a psychiatrist would know how, and they have hour-long consultations. So how do we create a structure that's safe, careful, kind for people in context?
Great answer. Okay, I'll now open it for anybody else's questions.
Everybody wants break, but I will be around all week. So if anybody's interested, love to chat.
Thank you, Denise. Okay, I just want to say that, so that concludes our fascinating and excellent session on weight bias, stigma, and body image. We would just want to say thank you to all our speakers for sharing such brilliant content, and also for keeping well within time as well. Thank you very much, and off you go and stretch your legs. Cheers.